Hello everyone. This video will be helpful for you to understand about the obstetric forceps, especially Wrigleys forceps. Objectives. In this video, we're going to learn about the definition of the Wrigleys forceps, characteristics, types, prerequisites, procedure onto how to apply the Wrigleys forceps, complications and failure of the Wrigleys forceps. First, we'll see the definition. Wrigleys forceps named after author Joseph Wrigley. It is used in low or outlet deliveries when the maximum diameter is about 2.5 centimeter or 0.98 inches above the vulva. Wrigleys forceps were designed for use by general practitioner obstetrician having the safety feature of an inability to reach high into pelvis. Obstetricians now use these forceps most commonly in cesarean delivery section where manual traction is proving difficult. The short length results in a lower chance of uterine rupture. So basically the Wrigleys forceps is used to extract the head or to pull the head in both deliveries, both vaginal and the cesarean section. Okay, so cesarean section they will use the hand to pop out the head. But if that is proving difficult, then forceps may be used, especially in the breech deliveries. Also in vaginal deliveries, if the baby's head is low, okay, if the baby's head is below the ischial spine and it is sitting on the perineum and the mother is very tired, in that case we'll go for this forceps extraction. There are many types of forceps. This video will be learning about the Wrigleys forceps. Characteristics. Obstetric forceps are composed of two separate blades, right and left. Insertion around the fetal head within the maternal vagina. Two shanks of varying length and two handles. Forceps are of two types, non-rotational and rotational. The blades have a cephalic curve to accommodate the form of the baby's head and are fenestrated, which are not solid, to minimize the trauma to baby's head during both placement and birth. So basically, this obstetric forceps will have two surfaces. Okay, the inner surface or the medial curve is called the concave surface is called the cephalic curve, while the outer is called the pelvic curve. Okay, the cephalic curve is fenestrated and it will not hurt the baby's head or it will not hurt the mother's vagina. Okay, so it is two uh, shanks. Okay, it has two shanks and it has two blades. Okay, each shank has one blade and it is not uh, together assembled. After putting onto the fetus head, okay, it will be locked. After that only it will be assembled. Till then there will be two separate blades. So that's about these characteristics of Wrigley's forceps. They also have a pelvic curve. As I said earlier, the pelvic curve will reduce the risk of trauma to the maternal tissues during birth. The blades are correctly positioned around the fetal skull and will be noted to lock with ease. Okay, so if you place the blade correctly, the locking will be easy. Okay, otherwise, if the lock is very tough, then it shows that the blade is not placed correctly. Okay, forceps that do not lock are most commonly incorrectly placed. Okay, next, classification of obstetric forceps. According to American College of Obstetrician and Gynecologists, there are four types: outlet forceps, low forceps, mid forceps, and high forceps. Outlet forceps delivery, where the forceps are applied when the fetal head has reached the perineal floor and its scalp is visible between contraction. Okay, so when you see the perineum and the mother is pushing, okay, if you see the perineum, the scalp is visible. So in that case only you can use this outlet forceps. And low forceps is when the baby's head is at +2 station. Okay, so if the outlet forceps means, we can say in other words it can be like +3 or 4 station, that is called outlet. When it is +2 station or lower, then low forceps can be used. There is no restriction on rotation for this type of delivery. The third one is mid forceps. where the baby's head is above plus 2 station. Okay, there must be head engagement before it can be carried out. Next is the high forceps delivery is not performed in modern obstetric practice. It would be a forceps assisted vaginal delivery performed when the baby's head is not yet engaged. Okay, so high forceps is not performed. It means that the baby's head is above the ischial spine. Okay, so according to ischial spine only we'll uh, calculate the station of the head. Okay, so if it is below 0 and plus 2, so above 0 it is minus 1, minus 2, minus 3, minus 4, minus 5. So if the baby's head is from 0 and minus 1 above, okay, it means above the ischial spine, it is called high forceps, which is not used in the modern obstetric practice because it will cause a lot of damage to mother's cervix as well as the perineum. In that case, most of the delivery will be taken for cesarean section. So first we'll see about the low cavity forceps, that is Wrigleys forceps. So it is used when the head is, as it is shown in the picture, the head is on the perineum or to assist the birth of the fetal head at cesarean section. They have a short shank. Shank means the handle where we hold the blade, that is called the shank, and fenestrated blades with both pelvic and cephalic curve and an English lock. Okay, so that is about the Wrigleys forceps. So they have a short shank, fenestrated blades, pelvic and cephalic curves, and a lock. Okay, so this Wrigleys forceps is used when the head is on the perineum. It means at plus 3 or 4 stations at outlet forceps. Okay, Wrigleys forceps, otherwise called as outlet forceps, or it can be used in the cesarean section also, where the delivery of the head is difficulty or delivery of the breech is difficulty. In that case also this Wrigleys forceps or outlet forceps is used. Next is Neville Barnes or Simpson's forceps. This forceps is used for low or mid cavity forceps when the sagittal suture is in the anteroposterior diameter of the cavity of pelvis, and they also have the cephalic and the pelvic curves, and the handles are longer and heavier than the Wrigleys forceps. Next is a Keyland forceps or high cavity forceps designed to deliver the fetal head at a station above the pelvic brim. It means above the ischial spine. Okay, they are now more commonly used for rotation and extraction of a baby whose head is in deep transverse or occipital posterior malposition. It allows for the safe rotation of the fetus. They are now considered unsafe, and a cesarean section will be preferred method of delivery in nearly all cases. So as I said earlier, the high cavity forceps are not used now, and the forceps which are supposed to use for this cavity station of the head is Keyland forceps. Okay, so because they are longer, okay, and they have a heavier handles, okay, and if the head is above the brim, this kind of high end forceps, high cavity forceps are used. So what are the prerequisites? So simply without any checking, you cannot put a forceps into a mother's perineum. Okay, so first you have to explain the rationale for the mother and get the consent, and catheterize the bladder. The cervix must be fully dilated and retract effaced, and the membrane should be ruptured. So continuous fetal heart rate monitoring should be there. Woman should be positioned with the legs either with dorsal recurrent position um, or in the lithotomy position. And location of the birth you have to consider before where are you going to deliver the baby, which is labor room or theater. And analgesia is very important. Can be inhalation analgesia, pudendal nerve block with the perineal infiltration, or an epidural anesthesia. Okay, so whatever analgesia is very important. So it can be local or inhalational or epidural. So if it is epidural which is already in situ, then it can be topped up. Okay, and or if there is no epidural, at least a spinal anesthetic should be administered before using the Keyland forceps. And ascertaining the precise position of the fetal head is very important. Okay, so we have to apply the blades of the forceps on the maxilla of the baby, okay, on the right and left maxillary bone. So ascertain the position, where is the sagittal suture, where is the coronal suture. So that is very important. Though historically it was accomplished by feeling the fetal skull with suture lines and fontanelles, in modern era this is ascertained by using ultrasound, so which is essentially mandatory before applying the keel and forceps or any for kind of forceps. Next we'll see about this. So this is about the prerequisites. Next is the technique of insertion. So how you are supposed to insert is, first left blade is inserted before the right blade, with the other hand protecting the vaginal wall from direct trauma, and the forceps blade come to lie in parallel to the axis of the fetal head and between the fetal head and pelvic wall. Then articulates and lock the blades, checking their application before applying the traction. So first left blade should be inserted, okay, along the vaginal wall and preventing the direct trauma to the mother's perineal tissues, and the right blade is applied, okay, in parallel to the other blade. Then it is articulated, but then both the blades are articulated and both the blades are locked, okay. And checking the during the lock we have to check the application of the blade, whether it is applied correctly or not. After that only it has to be locked and the traction should be applied. So traction should be applied in concert with the uterine contraction and maternal expulsive efforts. So whenever there is uterine contraction you can give gentle traction, otherwise you should not give any traction. Next is complications of this forceps delivery or Wrigleys forceps. Forceps are less likely than the ventouse to fail to achieve a vaginal birth, likely to be associated with a third or fourth degree tears. And so more than this ventouse, that is vacuum delivery, forceps delivery is minimally used because it is known to cause third and fourth degree perineal tear. Sometimes this perineal tear is very difficult to stitch and very difficult to arrest the bleeding, and sometimes it can also cause a rent. Rent means it can cause incontinence, okay. Fecal and urinary incontinence can occur, okay, and vaginal trauma can occur, and use of general anesthesia is there, and flatal, fecal and urinary incontinence, trauma or soft tissue damage occurring to the cervix, vagina and perineum, dysuria or the retention of urine and hemorrhage, okay, both from tissue and also due to uterine atony. So the risk of which is always increased following an assisted vaginal birth. So these are the maternal complications. Neonatal complication, marks on the baby's face, bruising can occur, commonly caused by the pressure from the forceps blades and around the caput succedaneum from the ventouse, all of which resolve within 48 to 72 hours after birth. Facial palsy, which may result from pressure from a blade compressing a facial nerve, a transient problem in most cases, and prolonged traction during a birth with a ventouse will increase the likelihood of scalp abrasion, cephalhematoma, or subaponeurotic bleeding. So all these are neonatal complications. Failure. So any instrumental or vaginal birth can result in failure also. It means whatever interventions we are trying to use, it will not result in the required, okay, the good result will not come. So that is called as failure. So that can occur. It means the birth of the delivery. At last we are going to achieve birth of the head, right? So that cannot be achieved because of these circumstances. Reason is inadequate case assessment, high head, misdiagnosis of position and attitude of the head, a long traction, and poor maternal effort with inadequate use of syntocin. So all this can result in failure with the forceps instrument. So thank you all. In this video we learned about the definition, okay, characteristics, types of the Wrigleys forceps, obstetric forceps, and the prerequisites, procedure, how to apply, complications and failure. Okay, thank you all. See you in the next video. Thank you.